Have you ever felt like a detective, trying to piece together clues to figure out what's going on with your own body? Well, in clinical medicine, that's pretty much the job description. Every single day, every symptom is a clue. Every lab result is a piece of evidence. And the puzzle is the human body itself. So today, we're going to put on our detective hats and solve a couple of these medical mysteries together.
So here's the deal. We've got two medical puzzles for you, pulled from some really fascinating clinical cases. I'm going to lay out all the clues, all the evidence, and your challenge is to see if you can crack these cases right along with me. You ready? Let's meet our first patient.
All right, let's dive into our first mystery. And this one's a real head-scratcher, not just for us, but for the patient and her doctors. It's the case of a weakness that just will not go away.
So here's the rundown. Our patient is a 58-year-old woman, and she's dealing with muscle weakness and cramps. Now here's the first clue that tells you something strange is going on. She's already taking potassium supplements, but they're doing absolutely nothing. And also, you're going to want to file this little detail away. She's on a very common blood pressure medication called hydrochlorothiazide. Trust me, that's going to turn out to be a huge clue.
Okay, the first round of lab work is back, and wow, this is where the clues really start flooding in. Her potassium is down at 2.9. That is dangerously low, and it's exactly why she's having that muscle weakness. Next up, her bicarbonate and her blood pH are both high. What that tells us is that her body's chemistry is way off balance, in a state we call metabolic alkalosis. And check this out, her kidneys are just dumping potassium into her urine way more than they should be. And finally, we get to the hormones. Renin is low, but aldosterone is high. Now that is a very specific and very telling pattern. The picture is getting clearer.
All right, detective, all the evidence is on the table. We've got the super low potassium, that weird metabolic alkalosis, and the bizarre hormone levels. So what in the world could be causing all of this? Let's start looking at our lineup of suspects. Okay, let's start narrowing it down. Could it be something called renal tubular acidosis? Well, the name kind of gives it away. That condition makes the blood too acidic. Our patient has the exact opposite problem. Her blood is too alkaline. It's a clear, direct mismatch. So we can safely cross that one right off the list. Okay, what about this one? Primary hyperaldosteronism. I mean, it looks pretty good at first, right? It causes high aldosterone. But the word primary means the problem starts in the adrenal gland itself, totally on its own, maybe from a tumor. But wait a second. Remember that crucial clue I told you to file away? Our patient is taking that diuretic, hydrochlorothiazide. What if the medication isn't just a detail? What if it's the trigger? And that leads us directly to our diagnosis, secondary hyperaldosteronism. See, the keyword here is secondary. This isn't a primary problem with her adrenal glands. They're working just fine. They're just producing all this extra aldosterone as a reaction to something else. And that something else is her blood pressure pill.
Let's just walk through this chain reaction, because it's a perfect cascade of events. First, the diuretic makes her body lose salt and water, which basically tricks her body into thinking it's dehydrated. In response, the body panics and flips on a system to save salt and water, which cranks aldosterone production way up. That super high aldosterone then tells the kidneys, save salt at all costs, and the cost is wasting potassium to do it. The final result, that severe low potassium that's causing all her symptoms, the whole mystery traces right back to that one prescription.
Okay, one mystery solved. Let's move on to our second case, which is, well, it's a whole different level of urgency. This isn't a slow-burning problem. This is a full-blown crisis.
So, meet our second patient, a 42-year-old man who comes into the hospital with sudden, terrifying symptoms, sharp chest pain, and he can't catch his breath. And the key piece of his medical history? He has nephrotic syndrome, which is a very serious kidney disease. And trust me, that is not a coincidence. The emergency team gets to work immediately, and the data coming back is alarming. His oxygen level is only 90%. He's literally starving for air. His albumin, which is a key protein in the blood, is incredibly low, which we'd expect with his kidney disease. But then you see this. His D-dimer level is over 2,000. That is a massive red flag that is practically screaming major blood clots somewhere in the body. And to top it off, his ECG shows this really specific pattern, S1Q3T3, that tells us the right side of his heart is under enormous strain, like it's trying to pump against a huge roadblock.
So why is this happening? Well, here's the hidden danger of his chronic condition. People with nephrotic syndrome are at a huge risk for blood clots. Think of it like this. Their damaged kidneys are like a leaky filter. They're supposed to keep all the good stuff in,
But instead, they accidentally flush out the body's natural built-in blood thinners into the urine. And without those protective proteins, their blood becomes dangerously thick and prone to clotting.
So the team orders an urgent CT scan of his chest. And there it is, the smoking gun, a massive blood clot. What we call a pulmonary embolism is blocking the main artery going to his right lung. This is what's causing the chest pain, the shortness of breath, the dangerously low oxygen. Mystery solved.
But, in the ER, figuring out what's wrong is only half the battle. Now comes the even more critical question. What do we do about it right now? We know it's a massive pulmonary embolism. So what's the right call? What's the immediate move?
Now, you might be tempted to go for the biggest gun in the arsenal, the most powerful clot buster drug, a treatment called thrombolysis. But that stuff is reserved for patients who are what we call hemodynamically unstable. They're in shock, their blood pressure's crashing. Our patient is in very serious trouble, for sure, but his vitals are holding steady. Using that powerful drug right now would actually be too aggressive and carry a lot of unnecessary risks. So the right move here is a medication called low molecular weight heparin. This is the standard of care, the go-to treatment for a stable patient just like him. It acts like a brake, stopping that clot from getting any bigger, and it gives the body a chance to start breaking it down on its own. It's safe, it's effective, and it's exactly what this patient needs in this moment. So 2 cases, 2 mysteries solved, and 2 patients now on the right track. Let's just zoom out for a second and think about what these 2 stories really teach us about the art of clinical reasoning. Here are the big takeaways, the key detective lessons. First, you always have to connect the dots between a patient's history, their medications, and what's happening to them right now, just like with the diuretic in case 1. Second, trust the labs. They tell the true, unbiased physiological story. Third, you have to know the risks. Understanding that nephrotic syndrome creates a huge risk for blood clots was the absolute key to solving case 2. And finally, and this is so important, you have to match the treatment to the threat, not just to the diagnosis. A patient's stability changes everything. And that really leaves us with one final crucial question. Both of these cases show how a chronic condition or even a simple, common medication can suddenly set the stage for a life-threatening crisis. It really makes you wonder, what other hidden links are out there, connecting the quiet, day-to-day state of our health to a sudden emergency? That right there is the constant, fascinating puzzle of clinical medicine. Thanks for putting on your detective hat with me today.